You know, usually when we talk about looking through a microscope, there's this expectation of obvious answers.
Right, like you're just going to spot the one rogue cell and instantly solve the case.
Exactly. You picture someone peering into the lens and yelling, aha. But if you are a medical student, a young professional, or really just a dedicated learner staring down the barrel of a pathology slide, you know the reality.
Yeah, the reality is often just a sea of confusing pink and purple blobs.
It really is. And it can be incredibly disorienting.
It is, yeah. Because it's not just about spotting a static pattern, It's about understanding the biological story unfolding in those tissues. You're looking at a dynamic, constantly changing environment.
Especially in the female reproductive system.
Oh, absolutely. Every shade of pink or purple is a clue to some structural or chemical shift.
Which is exactly why today's deep dive is so vital. We are pulling directly from the definitive textbook, Gynaecological and Obstetric Pathology for the MRCOG and Beyond.
Edited by Michael Wells, Hilary Buckley, and Harold Fox. Yes, it's a fantastic resource. It really is. And our mission today is to use that source to decode those blobs. We're going to take a journey right through the female reproductive tract.
Starting from the anatomical entrance, moving up into the uterus, out to the adnexa, and finally into the placenta.
Right. And the goal here is to bridge the gap between pure cellular pathology and everyday clinical practice. No basic jargon, just pure, clinically accurate insights.
We want to extract the exact histological hallmarks you need to know. But more importantly, we want to explain the underlying mechanisms. Why does a disease look the way it does?
And how does that dictate patient care? So let's just jump right in. Let's start at the very beginning of the tract, the vulva, the vagina, and the cervix.
Perfect place to start.
Now, you might think of the vulva as being prone mostly to, local skin issues or localized infections. But at the cellular level, something really surprising happens.
It does. Systemic conditions, things you'd associate with entirely different parts of the body, can actually manifest right there.
It's a critical paradigm shift, right?
Yeah.
Yeah, completely. The vulva is not isolated from systemic inflammatory responses. A really classic example of this is Crohn's disease.
Wait, Crohn's disease? As in the inflammatory bowel condition?
The very same.
How does a bowel condition end up causing lesions on the vulva? That sounds crazy.
Well, you have to remember the systemic nature of inflammatory infiltrates. Crohn's isn't just a localized reaction to a gut bug.
Right.
It's a systemic disorder of the immune system characterized by granulomatous inflammation. The immune system is essentially misfiring.
Forming those tightly packed clusters of white blood cells.
Exactly. So under the microscope, if a pathologist looks at a vulvar biopsy from a patient with vulvar Crohn's, they'll see very specific structures.
What are we looking for exactly?
You'll see non-case-seating granulomas containing giant cells, and they're usually surrounded by a really heavy lymphocytic infiltrate.
So it's the exact same immune mechanism that attacks the gut, just setting up camp in the dermal layers of the vulva.
Precisely. The immune cells, they don't know they're in the wrong location. They're just following a flawed systemic blueprint.
Wow. That is a massive clinical pearl for you listening. If you see those non-caseating granulomas and giant cells on a vulvar biopsy, you can't just tunnel vision on a local infection.
No, you really can't. You have to step back and ask, could this patient have undiagnosed Crohn's disease?
Because that completely changes the treatment plan, right? From topical creams to systemic immune management.
Exactly right. It changes everything.
Now, that deceptive surface presentation actually perfectly sets us up for what happens when we move slightly up the track to the vagina.
Oh, yes. Sarcoma botryoides.
Right. Embryonal rhabdomyosarcoma. It typically presents in young girls as these polypoid masses protruding from the vagina. But histologically, it's incredibly sneaky.
It is the ultimate Trojan horse.
Because the covering squamous epithelium of the vagina might look perfectly normal under the microscope, right?
Yeah, the surface cells are orderly and well-behaved. But beneath that normal epithelium, down in the soft tissue, it is a completely different story.
What's hiding down there?
You find these distinct strap-like striated muscle cells.
Trap cells.
Yes. These are primitive, malignant muscle cells that have gone completely rogue. They're attempting to form skeletal muscle in a place where it absolutely does not belong.
And they're proliferating wildly.
Uncontrollably. So recognizing those elongated strap-like cells beneath the normal surface, that is the definitive hallmark of this aggressive sarcoma.
That deceptive behavior really prepares us for what happens next door in the cervix. Because there, The ultimate deceptive invader, the human papillomavirus, or HPV, is pulling off a similar trick.
Hiding its destructive behavior deep in the epithelial layers, yeah.
Right. When we look at cervical intraepithelial neoplasia, or its CIN, the grading system is incredibly structural. I actually like to think of it like a hostile takeover of a factory.
I like that analogy. Let's explore that factory. How does the takeover happen?
So the cervical epithelium is our factory. It has multiple floors, from the basement membrane at the bottom all the way up to the surface layer.
Okay, I'm with you.
In CIN1, the lower grade, the viral invaders have just taken over the ground floor. You see abnormal cells down low, but the upper two-thirds of the epithelium are still showing normal cytoplasmic maturation.
So the factory is still mostly doing its normal job of producing healthy cells at the top.
Exactly. But as the infection drives further genomic instability, it progresses to CIN2.
Right, the takeover moves upstairs.
Yeah. In CIN2, that normal maturation is restricted only to the outer third of the epithelium. The invaders have disrupted management all the way up through the middle floors.
Pushing higher and higher toward the surface. That is a highly accurate visualization.
Thanks. So if we zoom in on the specific cells in that hijacked factory, we see the exact fingerprint of the viral invader, right? The coilocyte?
Yes, the coilocyte. When HPV infects these cells, it creates a very distinct cytopathic effect. You'll see multinucleated cells with enlarged hyperchromatic nuclei.
Let's break down that word, hyperchromatic. Why do they look so incredibly dark under the microscope?
It's purely mechanical, actually. The virus has completely hijacked the cell's replication machinery to mass-produce raw viral DNA.
It's just pumping it out.
Right. And all that densely packed genetic material absorbs the dark purple hematoxylin stain really intensely.
Oh, wow.
So you have this massive, dark, irregular nucleus, and it's often surrounded by a clear halo in the pink cytoplasm.
Which is a result of degenerative changes caused by the virus.
Exactly. That complete visual. The dark, packed nucleus inside a clear halo is a coilocyte. Seeing them tells you definitively that HPV is actively driving the cellular chaos.
Now, this idea of viral disruption in the cervix contrasts sharply with what's supposed to be a highly regulated, predictable environment right next door to the uterus.
Oh, the architecture changes completely here.
Because the uterus isn't just a static organ, it's a hormonal playground.
Yeah.
The endometrium changes so predictably that it's basically a biological clock.
It truly is. During a woman's reproductive years, right after ovulation, the endometrium undergoes an orderly, time-related pattern of changes.
It's incredibly precise, isn't it?
Very. A skilled pathologist can look at a slide and estimate the exact stage of the menstrual cycle to within 24 to 48 hours.
Just from looking at the cells.
Yeah. They watch the glands become beautifully distended and angular, and they watch the surrounding stroma become edematous. It's a precise morphological response to progesterone, preparing to receive an embryo.
And when pregnancy actually occurs, that hormonal response just goes into absolute overdrive.
It really does.
There's a very specific histological finding called Aries stella change. During pregnancy, the glands become heavily hypersecretory, and the epithelial cells undergo variable vacuolation.
Meaning they develop these clear, fluid-filled spaces inside them as they pump out nutrients.
Right. But here is the critical detail from the source material. Aries stella change happens in intercauterine pregnancies and in ectopic pregnancies.
That is correct. It's a strict response to the hormones of pregnancy, specifically HCG and progesterone.
So the endometrium reacts to those hormones regardless of where the concept is actually implanted.
Yes. The tissue responds to the systemic hormone levels, not the physical location of the embryo.
But wait, if Aries stella change happens in the uterus even during an ectopic pregnancy, couldn't a pathologist look at an endometrial biopsy, see this hypersecretory change, and falsely reassure the clinician that the pregnancy is safely inside the uterus? That seems like a massive diagnostic trap.
It is the absolute definition of a diagnostic trap, and it's a classic pitfall that can cost a patient her life.
Wow.
Yeah. Aries stella change in the endometrium merely confirms that a pregnancy exists somewhere in the patient's body.
Yeah.
It's just the soil reacting to the hormonal weather, so to speak.
So finding it in a uterine sample without seeing any actual fetal tissue specifically, finding zero chorionic villi does not guarantee the pregnancy is safe.
Not at all. In fact, if you see Aries stella change but no villi, your index of suspicion for a life-threatening ectopic pregnancy should immediately skyrocket.
That is terrifying, but so important. You cannot rely on the secondary hormonal changes. You have to find the actual placental tissue.
Exactly.
Now, While we are in the uterus, we also have to talk about the muscle layer, the myometrium, and its most famous residents, leiomyomas or fibroids.
Leiomyomas are very common benign tumors. They're composed of interweaving bands of elongated, smooth muscle cells.
And they can get pretty big, right?
Very large. And because they're encapsulated and can grow so much, they eventually run into a major mechanical limitation. They outgrow their own blood supply.
They basically get too big to feed themselves.
Exactly. And when tissues lose their blood supply, they undergo degenerative changes. But there's a very specific type of necrosis called red degeneration that occurs particularly during pregnancy.
Why pregnancy specifically? What's the mechanism there?
Well, during pregnancy, the fibroid grows incredibly rapidly due to the massive surge in circulating hormones.
Okay.
Because it's growing so fast, the thin-walled veins at the periphery of the fibroid become compressed and obstructed, but the thick-walled arteries keep pumping blood in.
Oh, so blood goes in but can't get out.
Exactly. This leads to intense venous stasis and massive hemorrhagic necrosis. If a surgeon cuts into it, it literally looks like raw red meat.
Ouch!
Yeah, microscopically, you'll see dead, smooth muscle cells swimming in massive hemorrhage. It causes severe acute abdominal pain for the pregnant patient.
That makes total sense. And outgrowing a blood supply is a purely mechanical failure, which perfectly primes us for our next anatomical zone, the adnexa.
The fallopian tubes and the ovaries.
Right. This is a zone where delicate architecture means structural disruptions have catastrophic consequences. Let's start with the fallopian tubes. These are essentially narrow, ciliated corridors designed to transport a microscopic egg.
And any disruption to that corridor is devastating for fertility. A prime example is salpingitis ismica nodosa.
Which is essentially diverticular disease of the fallopian tube.
Right. You get these glandular spaces butting down deep into the muscular wall of the tube. This structural outpouching completely ruins the smooth, ciliary transport mechanism needed to sweep the egg toward the uterus.
So the egg gets trapped.
It gets trapped, heavily predisposing the patient to an ectopic pregnancy. Furthermore, this delicate architecture can be completely ruined by parasites.
Like schistosomiasis.
Yes.
Which is a vital global health perspective.
Yeah.
In women who have traveled to or lived in endemic areas like East Africa, the parasitic eggs can actually lodge in the pelvic organs.
And the immune system recognizes those eggs and launches a massive granulomatous inflammatory response. The resulting scarring essentially cements the tube shut.
It's all about blockages in the adnexa, and that leads directly to a fascinating and, frankly, frightening ovarian emergency, massive edema of the ovary.
Oh, this one is striking. The ovary can swell up to 25 centimeters in diameter.
That's the size of a melon.
It is. And it completely mimics a massive malignant tumor, presenting as a terrifying acute abdomen.
But the underlying mechanism isn't cancer at all. It's purely mechanical, right? It's driven by intermittent torsion or twisting of the ovary on its pedicle.
Yes.
But why does it swell to the size of a melon instead of just, losing its blood supply and dying immediately?
Because of mechanical asymmetry. The twisting is partial or intermittent. It's just tight enough to compress the thin-walled veins and lymphatic vessels, which are supposed to drain fluid out.
But the arteries stay open.
Exactly. The thick-walled, high-pressure arteries keep pumping blood into the ovary.
It's like leaving the garden hose on but plugging the drain.
Precisely. Fluid rushes in, but it cannot get out.
Yeah.
The ovarian stroma just fills with edema fluid, inflating the organ to a massive size.
That mechanical asymmetry is wild. Now, while we are in the pelvis, we have to talk about endometriosis.
Yes, ectopic endometrial tissue growing outside the uterus.
We often hear about chocolate cysts forming in the ovaries. This is from the ectopic tissue bleeding during the menstrual cycle and the blood becoming trapped and turning into this thick, tarry fluid.
But the critical point from our source material is that the blood isn't just taking up space.
No, the trapped blood is actively destructive.
When that old blood breaks down, it releases free iron from the degraded hemoglobin.
And this is where my rogue demolition crew analogy comes in.
Let's hear it.
Endometriosis isn't just a benign squatter taking up real estate. That free iron acts like a toxic superglue. It creates reactive oxygen species, which triggers macrophages to rush in and try to clean up the mess.
Right, and those macrophages release intensely fibrogenic cytokine.
Exactly. This triggers massive scarring, creating dense, organ-fusing adhesions that ruin the normal anatomy of the pelvis. It literally binds the bowel to the uterus and the ovaries to the pelvic sidewall.
That toxic superglue visual is painfully accurate.
Yeah.
The iron-induced fibrosis cascade is what causes the chronic, severe pain and infertility associated with advanced
It
endometriosis.
just cements everything together.
It does. The primary lesions actually get completely obscured by this incredibly dense fibrous response.
Before we leave the ovaries, we have to touch on ovarian tumors, specifically the granulosa cell tumor.
Granulosa cell tumors are fascinating because they are sex cord stromal tumors. They don't just grow and take up space, they are biologically active.
They secrete hormones. Right. Most commonly, massive amounts of estrogen.
They're essentially rogue estrogen factories.
Mm.
And the clinical presentation entirely depends on the age of the patient.
Let's unpack that. If this estrogen-secreting tumor develops in a young child, the sudden influx of hormones causes isosexual precocious pseudopuberty.
Yes.
But if it develops in an older postmenopausal woman, that estrogen stimulates the dormant uterine lining, causing endometrial hyperplasia and postmenopausal bleeding.
The symptom is the direct clue to the hormone, which is the direct clue to the tumor.
And histologically, if you're looking at the slide, you are hunting for a very specific microscopic signature, right? Call Exner bodies.
Yes, call Exner bodies. The tumor cells often arrange themselves in these delicate microfollicular patterns.
Little rosettes.
Exactly, little rosettes of cells surrounding a central space filled with pink eosinophilic fluid. Finding those rosettes confirms the diagnosis.
Right, so if those fallopian tubes stay open and an egg actually makes it through that gauntlet to implant safely in the uterus, we get the development of the placenta.
Our fourth anatomical zone.
The placenta is an incredible temporary organ, the fetal life support system, but it's also a potential battleground of vascular insufficiency and ascending infection.
Let's start with early failures. Distinguishing a normal miscarriage from a precancerous molar pregnancy.
Okay, so about 15% of recognized pregnancies end in a spontaneous miscarriage. If the fetal demise happens very early, the placenta often shows hydropic change. The chorionic villi become extremely edematous and swollen.
But wait, swollen, fluid-filled villi. Isn't that also the exact definition of a molar pregnancy, a hydatidiform mole?
Yeah, that's the question. How do you tell the difference between a sad but normal miscarriage and a potentially dangerous mole?
It's all in the trophoblast. That's the layer of specialized cells covering those swollen villi. In a hydatidiform mole, the disease is genetically driven to proliferate wildly.
So it's overgrown.
Right, the trophoblastic mantle is wildly hyperplastic. It's growing in thick, chaotic layers. But in a hydropic miscarriage, the fetus has died.
And without a growing fetus sending chemical signals.
Exactly. Without those signals, the covering trophoblast is attenuated. It's stretched incredibly thin, shrunken, and inactive. Attenuated means miscarriage. Hyperplastic means mole.
That is a critical distinction, driven entirely by the presence or absence of growth signals. Now, moving to later in pregnancy, the pathology of placental infarcts is fascinating.
Oh, definitely. Under the microscope, old infarcts appear as hard white plaques made of crowded ghost villi.
Crowded ghost villi, it sounds incredibly eerie.
It's a striking visual. The trophoblast has undergone complete necrobiosis cell death, leaving only the pale, structural outlines, the ghosts of the villi.
Wait, if a pathologist is looking at a placenta full of dead, infarcted ghost villi, doesn't that just mean the dead tissue starved the baby? I mean, less functioning placenta means less food, right?
That's the intuitive leap, for sure, but the biological reality is slightly different. The infarct itself isn't the primary cause of fetal complications.
It's not.
No, a healthy placenta has enough reserve capacity to handle a few dead patches. We have to think about why the tissue infarcted in the first place.
Okay, so what is the cause?
It's usually due to thrombosis, or clotting, in the maternal uteroplacental vessels. Extensive infarction implies widespread maternal vascular disease, like the acute atherosis we see in preeclampsia.
So the ghost villi are just the victims.
Precisely. The true threat to the fetus is the severely restricted maternal blood supply that caused the infarcts in the first place.
Ah, I see.
The dead patches are merely the visible gravestones of a failing maternal vasculature. It's the underlying global lack of blood flow that causes fetal growth restriction.
It's a symptom of the system failing, not the root cause. We also need to talk about what happens when the placental environment gets breached from below. Ascending infections causing chorioamnionitis.
This is a major etiological factor in preterm labor, particularly before the 35th week. Bacteria ascend from the birth canal, and you get a dense infiltration of neutrophil polymorphonuclear leukocytes, white blood cells, into the fetal membranes.
The biochemical cascade here is elegant but devastating. The bacterial infection brings in the neutrophils. This triggers activated macrophages in the tissue to release inflammatory cytokines.
And those cytokines then chemically stimulate the amniotic and decidual cells to synthesize massive amounts of prostaglandins.
And as anyone in obstetrics knows, prostaglandins are the specific chemical trigger that initiates uterine contractions. The bacterial infection literally biochemically tricks the uterus into starting labor.
It's a perfect, albeit pathological, chain reaction. And briefly, we must mention placental adherence issues. When it comes time for the placenta to detach after birth, sometimes it refuses. This is placenta accreta.
The villi adheres directly to the myometrium, the uterine muscle. Why does this happen mechanically?
The pathological basis is a partial or complete absence of the decidua basalis.
Remind us what the decidua does.
The decidua is normally the spongy endometrial layer that acts as the separation plane. Without it, the invasive trophoblast anchors directly into the deep muscle,
Leading to severe, life-threatening hemorrhage when the clinician attempts to deliver the placenta.
Exactly. It just won't detach safely.
Okay, we've covered all this complex tissue architecture, but how do we catch these rogue cells before they destroy the architecture? This brings us to cytology.
We aren't taking chunks of tissue here. We are looking at individual cells.
Cervical cytology, the pap smear, is the classic frontline example. Population screening prevents up to 4,500 deaths a year in England alone.
We're looking for dyskaryosis, which literally means abnormal nuclei.
Right. Under the microscope, these nuclei are enlarged, darkly stained, and have irregular borders. Spotting dyskaryosis warns us of pre-malignancy years before it becomes invasive cancer.
But cytology isn't just for the cervix. It is highly advanced. If a surgeon suspects an ovarian or tubal malignancy, they will wash the pelvic cavity with fluid and send that fluid to pathology.
But think about how terrifying that is. If they find a cluster of malignant adenocarcinoma cells floating in that wash fluid, how do they actually know those cells came from the ovary and didn't just shed off a primary tumor in the gastrointestinal tract?
That is where modern pathology relies on immunohistochemistry. We can stain the cells for specific structural proteins.
How does that work?
Inside the skeleton of epithelial cells are intermediate filaments called cytokeratins. Different types of tissue use different cytokeratins. They act like cellular zip codes.
Cellular zip codes, I love that. So how does the stain actually read the zip code?
We use antibodies engineered in a lab to seek out specific cytokeratins, like cytokeratin 7 and 20. If the antibody finds its specific target inside the cancer cell, it binds to it like a lock and key.
And then what?
We add a chemical that turns that bound antibody a bright brown or red color. A primary ovarian adenocarcinoma will usually be positive for cytokeratin 7, but negative for cytokeratin 20.
And GI cancers are different.
Gastrointestinal cancers have the exact opposite profile. By dropping these specific antibody stains onto the slide, the pathologist can literally color code the origin of a single cancer cell floating in a sea of fluid.
That mechanism is absolutely incredible. It takes all the guesswork out of the diagnosis.
It really does. It's a game changer.
Okay, let's bring this all together. We have traveled from the hyperchromatic viral factories of HPV invading the cervix through the timed hormonal precision of the endometrium.
We've seen how rogue iron acts as a toxic superglue in endometriosis, and how ghost villi maps the failure of maternal blood flow in the placenta.
And through it all, the underlying lesson is that pathology is not rote memorization.
No, absolutely not. Recognizing these hallmarks, whether it's strap cell, a Call-Exner body, or an attenuated trophoblast, it's about understanding the structural, chemical, and mechanical forces driving the disease.
That is what separates a passive observer from a clinician capable of life-saving deduction.
Well said.
To really cement that idea, and as requested for this specific deep dive, we are going to leave you with a clinical scenario to test what you've learned today. Put yourself at the microscope.
All right, here is the exercise for you. You are examining an endometrial biopsy from a patient presenting with abnormal bleeding and abdominal pain.
Okay.
You look at the slide and clearly identify heavily hypersecretory glands and epithelial cells with distinct vacuolation. It is textbook area stella change.
The hormonal weather response.
Exactly. However, as you scan the entire slide, you realize there are absolutely zero chorionic villi in the sample. Based on the biological mechanisms we've discussed today, where must your mind immediately go?
And what life-threatening condition are you now racing to rule out?
Think about the hormonal trap.
Think about what that missing tissue implies. We'll leave you to ponder that diagnosis. Until next time, keep digging deeper.